Hello.
Hello.
Can you hear me, Dr. Nadeem?
Yeah, I can hear you now.
Oh, sorry, I did not put the microphone on the side. I'm so sorry for that.
All
Yeah.
right. Okay,
Cool.
doesn't matter. Just give us a minute. We'll start, right?
Mhm.
Okay, fine. No, you're ready?
Yeah.
So just we'll be live on YouTube in a minute, right?
Mhm. Sure.
Good evening, everybody. Welcome to this evening episode of Pursue One Special Uropathology. And we are streaming live from MRI Bhubaneswar via Kolkata. And today we have with us Dr. Sambit Mohanty, who just does not need any introduction. Everybody probably knows him. And today's topic is very special. It's morphological underpinnings on prostate cancer and its cytoarchitectural imitates. This is a very important topic for everybody, and it is a topic on demand. And who better than Dr. Mohanty to take this up? And I think everybody knows Dr. Mohanty. So before I ask Dr. Mohanty to take over, let me ask everybody, please keep your mic muted, please keep your camera off, and please don't share your screen. With this, let me request Dr. Mohanty to start. Sir, please start. Thank you.
Thank you, Dr. Nadeem. I have to share my
Just
screen.
share your
Okay.
present
Yeah.
now and share your screen.
Fantastic. Yeah. Entire screen.
Yeah.
I think. Yeah.
Yeah, I can see your screen coming. It's on the way. It's not yet
Cool.
up. Yeah, you can make
Okay.
it full screen.
Cool. So is it visible?
Yeah, it's perfectly visible. Please start. Thank
Okay.
you so much.
Right.
Bye-bye.
Yeah. Thank you, Dr. Nadeem, and good evening, everyone. So I thought like I will touch upon the various morphologic features and where we are in prostate cancer and the mimics or the imitates which resemble the benign things but resemble prostate cancer and some other issues. So I'll try to finish up everything today. If not, we'll have another class. So these are some disclosures I use for all my talks. So do not wasting time. Prostate cancer. It was a relatively easier disease. We have digital rectal examination, upper rectal examination, serum PSA, and you can do the examination. There is a hard nodule. The prostate is typically people have a believe like the BPH, the prostate cancer, the prostate is the size is increased. Not true. In prostate cancer, the size is usually normal or low as compared to the BPH. And BPH is a disease of the central zone, and prostate cancer is a disease of the peripheral zone. You can have central zone cancer, but majority of the prostate cancer derives from the peripheral zone or the subcapsular zone. As pathologists, we need to tell them what is the serum PSA, amount of tumor in the biopsy, what is the Gleason score. So it was easy, right? No, it is not that easy. So prostate cancer is the most common cancer among the American men, following next to the skin cancer. And for 2018 and 19 statistics, there's about 164,000 new cases and about 30,000 deaths from prostate cancer. The various risk factors is rare below 40 years, but it can be possible. Increases sequentially and rapidly after 50 years. African American ancestry, they more often have prostatic cancer and they more likely die of the cancer. It is less common in the Asians and Hispanic men and also in Indian. If there is a family history of father or brother with prostatic carcinoma, the person is at about twice at risk of developing cancer. Let's talk about India. The prevalence of prostate cancer in India is still low, but is increasing. Why? The factors which are responsible for increased pickup rate of cancer, increased migration of the rural population to the urban health centers, urban areas, change in the lifestyle, people are coming for health checkups, increased awareness, and the socio-economic milieu is changing with relatively easier accessibility to medical facility. So we are not far behind the Western Hemisphere in picking up with prostate cancer. And also, we are doing well. Pathologist, when I was a resident at PGI from 96 to 2003, my residency and senior residency time, that time we get a very few prostate biopsies. It was more like TURP chips. Prostate cancer was not that much. But gradually now we are getting 6, 12 core and more cores of prostate needle core biopsies. And whenever there is an increased PSA, the patient is subjected to needle core biopsy, either blinded or by trust guided biopsy. So it has been improved, and the detection technologies were also improved. So the first leading site is not a second, it's the first leading site among the male in Delhi, Kolkata, Pune, and Trivandrum. Second one is Bangalore and Bombay. And among the top 10 sites, these are the statistics, the annual percentage statistics. It was published about 6 years ago, starting from Chennai, Delhi, Mumbai, and but the changes now, Delhi is picking up as the highest. So they're the top 10 sites in India with prostate cancer. So this is something, an outlier, I'm not going to talk about it. So yeah. So what is required from us as pathologists? A general surgical pathologist, not necessarily a geopathologist. Every pathologist, we need to tell a lot of things to the urologist. Is there cancer or not? So we have to be 100% sure cancer is there or not. Number two, how my report is going to value or put a flavor to the clinical management. That means whether the patient is going to have action. And what am I going to base my report on? The certain serum markers like PSA, digital rectal examination, morphology, and other things take into account. I have to give a report. So within the diagnostic armamentarium, as pathologists, we are required, and it is mandatory for us to identify the pathologic features in both the biopsy and, if at all, there is a subsequent radical prostatectomy specimen to allow appropriate risk stratification to the patient. Why I'm using risk stratification instead of saying appropriate diagnosis? Because our is to tell them the diagnosis and talk to the patient. I mean, all my prostate biopsies when I report, I do not send the report to the urologist directly. Specifically my prostate biopsies are not delivered directly from the, does not send the report to the urologist directly. Specifically my prostate biopsies are not delivered directly from the dispatch desk to the patient. They come to my room, I check their file, give them the report, and give a kind of a, before they go to the urologist, they know what all questions they're going to ask the urologist. And that counseling part, the counseling parts in any cancer basically starts from the pathologist. So pathologists are they are the backbone. They're not the backbone actually. We always think we are the kind of in the orchestra. We're not doing anything on the field, or we are basically behind the scene. That is completely wrong. We are very much ahead, and we are very much on the screen and on the stage to play them. And basically we start, and we kind of walk them throughout the process. So it was the Gleason grading, you all know, it was established as a prognostic indicator that stood the test of the time, devised in 1966 by Dr. Gleason and members of the Veteran Hospital Group at Minnesota. So what it was based entirely on architectural patterns using a 5-tier scale in which the sum of the two most common patterns defines the Gleason score in a case, which starts from G2 to G10. We have evolved. And this is the most dominant pathologic factor till date due to its correlation with the disease stage biochemical recurrence, that means PSA recurrence, clinical recurrence, a presence of metastasis, local recurrence, and disease-free survival. And it is the most important cornerstone in management counseling. So for that reason, I said Gleason scoring, grading, and group grading, everything comes from the pathologist's desk. So we are the person we are going to counsel and management patients. There has been several modifications which have been triggered by change in the clinical practice. The patient is seen by a urologist versus a general surgeon, and the better understanding of the cancer histologic spectrum, the variants of prostate cancer it mimics, and the prognostic significance of everything, each and everything. So PSA and imaging techniques are usually used to do the biopsy. They have range from 2 biopsies to 6 to 12 to more. In that way, we can systematically map the gland. The information that is used to determine the therapeutic options and follow-up, more the number of cores, extent of resection, knob sparing or not, nature and dosing of the radiotherapy. Submission should be uniform. Which part it is coming from in different bottles or jars, not like everything mixed up in one jar. Please encourage your urologist. And knowledge in the specific location avoids diagnostic pitfall. Prostatic central zone for high-grade prostatic intraepithelial neoplasia and seminal vesicle for prostatic cancer. Those are usual pitfalls. So you need to know where it is coming from and what are the other normal structures which are present in that location. How are the normal prostate glands in that location? They're small or big. Then the amount of cancer in different regions are correlated with pathologic T stage and margin status. So that is something important. Then the next point being the biopsies should be separated. Inking multiple cores in different color, again, it gives a lot of problems. So do not do that. Fragmentation again leads to a lot of problems. So if you have a biopsy from a particular site, put it in a separate container and label it accordingly. So what are the criteria before we even go into the mimics? When Dr. Nadeem said like we should talk about the mimics, as a mimic is a good thing, is a good one. We all get confused. But we need to know what are the diagnostic criteria prostatic acinar adenocarcinoma. I'm not talking about the ductal, I'm talking about the acinar adenocarcinomas when I say PCA. So the major criteria are you have infiltrative small glands. So these are the larger glands. These are large normal glands. So prostatic acinar adenocarcinoma is, in most of the time, it is a small gland disease, or it is a proliferation of the small gland. These are benign glands, and these are the malignant glands. These are benign. This one, this one, this one, this one. These are all benign glands. So what you see, you have infiltrative glands which are going in between benign glands. Presence of cribriforming. That those are major criteria. Those are not the diagnostic sine qua non. You can have little infiltrative pattern in the mimics and cribriforming in basal cell hyperplasia or cribriform hyperplasia in the BPH nodule. Single cell layer, yes. Absence of basal cell layer is one of the very important criteria. And you have nuclear enlargement and nucleolar enlargement of the tumor cells. What are the minor criteria? You see some mitotic figures. Mitotic figures, trust me, are not readily discernible in prostate. And the Ki67 is usually low even in the highest Gleason of prostate cancer. So if you're using Ki to differentiate a BPH or a benign gland from the malignant gland, it's not going to appear in use. Then, presence of pink amorphous secretions, intraluminal blue mucin, intraluminal eosinophilic crystalloids, adjacent high-grade prostatic intraepithelial neoplasia, amphiphilic cytoplasm, nuclear hyperchromasia. Let's go one by one. So what do you see? You have blue mucin here. This blue tinged mucin or the blue stuff which is inside the gland is what I call blue mucin. And these are infiltrative gland in between. Another thing, can someone comment on one of the trainees can comment on the desmoplastic reaction on this slide? Anyone you can kind of unmute and answer, because there's a important kind of rationale behind me asking you this question. Do you see desmoplastic stromal reaction here? We have benign glands and we have malignant glands. This is a malignant gland. So I want one of you to kind of answer who are either a senior resident or a fellow or a resident.
Not much desmoplastic reaction, sir.
Yes, very good. Actually, if you kind of see, just forget about the glands, you just look into the background. The background looks kind of uniformly pink. There are some light pink areas, some nuclei. We do not know what kind of nuclei this are. Probably fibroblast, myofibroblast, we do not know, and some this wispy, smooth muscle. So desmoplastic reaction is not usually seen in prostatic adenocarcinoma. That is one thing. Mitotic figures are not readily discernible. Nuclear chromatin is usually opened up. So those are the few features you need to know about prostate. The regular saga, hypochromasia, pleomorphism, all these nuclear contour, regularity, nuclear envelope being very irregular, those are not visible in prostate cancer. They are very, very monotonous and monomorphic. Mitotic figures are not seen. I would say not seen. If you get it, is you are lucky, but it's not usually seen. Desmoplastic reaction is either absent or minimal. They are not very destructive kind of lesion. Though they are aggressive tumors, they are not very destructive. And what is happening here in this, if you see, and the glands, the malignant glands, they look paler as compared to, they look lighter or less basophilic as compared to the benign glands. If you see here, the benign glands look like more dark, they're darker or more basophilic, and the malignant glands, they look more like gray. They look gray. And they have nucleoli and monomorphic nuclei. What is this? Anyone? Anyone from you? What is this structure? This is a glomerulation again. Looks like a glomerular tuft with some afferent infrared arteriole, and this is within another tuft. How about this? These are the eosinophilic crystalloids, and usually eosinophilic crystalloids, they have a purplish exterior, and these are the glands. And these are again eosinophilic crystalloids. This is one layer. How about this one? This is also one layer. This is also one. How about this one? Is it basal cell layer or there's something else is happening? Like here also. It looks like there are 3-4 layers. Here also it looks like there are 2 layers. So it is malignant or benign. I do see nuclear enlargement, vesicular kind of nucleus with some finely dispersed chromatin, and usually they're kind of dispersed towards the periphery to the nuclear membrane. But I'm looking at here, I mean, traditionally by textbook teaching you see is the fundamental thing is the loss of basal cell layer. But here you have 2 layers. Here also 2 layers. It may be a tangent, but here it doesn't look like a tangent. So why there are 2 layers? I need some answer, guys. I need help. I do not know much about it. Please. Anyone? So these are basically malignant luminal cells, or the malignant epithelial cells of the prostatic acini, and there is stratification of the malignant cells. So this is something called stratification multilayering of the malignant cells. That also can happen. How about here? You have again blue mucin with multilayering of the stratification of the luminal cell, and this is a benign gland. So pathognomonic features are perineural invasion. So they kind of try to engulf the entire I would say circumferential perineural invasion. That is important. And glomerulations, mucinous fibroplasia, or collagenous micronodules. This is, they're kind of wrapping up the nerve completely. They're eating it up. Glomerulations, what we saw before. And this eosinophilic collagenous nodule inside this cribriform structure. It's all covered, I don't know how. So this is originally starting way back from the first publication in 1992. We have evolved into 2010. And if you see here, it was extremely cumbersome before. And gradually, there is not much change in 1 and 2, but gradually from 3 onwards, they are kind of changing. And if you see now, the 3 is a very uniform entity. So there's contraction of 3 and expansion of 4. 4 is getting complex and complex. We'll see that. So in 2016 and followed by that and till date, what we have, the 3 is a relatively kind of homogeneous entity. So there is significant contraction of Gleason 3 and expansion of Gleason 4 and introduction of grade group, which is 1 to 5. Cells show you. 1 is like a well circumscribed nodule, 2 is also well circumscribed. We do not see a little any stroma here, there's maybe a little bit stroma here. Here it is infiltrative with the normal glands, and you can see the gland lumen and the space between the gland and 4. If it is cribriform, or you see fused gland, or the glands juxtaposed to each other, but you still can see some lumen, then it is 4, and 5 is solid. And necrosis again is going to be 5. So this is a cribriform pattern 4 tumor. This is the glomerulation 4, and this is 3 or 4. I seriously need help in this slide. This is this. How would you grade this? 3 or 4? Am I audible, Dr. Nadeem?
Yeah, you are clear. You are audible. Only thing is your pointer is not visible at times. If you can just change your pointer to the laser version.
Okay, I'll do that. I'll do that.
Right click and change it. Yeah.
Yeah. Highlight.
Go to laser.
I have an arrow, ballpoint, ink. Maybe I'll just do ballpoint. Yeah. So this area, I would say this area, what I'm kind of.
Okay. Yeah, it's better now.
Yeah. So this one I know it is like a glomerular. So we are this is 4. How about these glands, these little ones, which are these glands? It is 3 or 4. Because there is problem. I do see there are a lot of consult cases that people come up with problems.
We have answers coming from YouTube. Nilesh Kapadia is saying 4.
Okay. Any 3?
3.
Okay. So why you think 3? I mean, you may be right. I'm not saying. Why it is important to say it is 3 and 4? Because once you have 4 in a biopsy, watchful expectancy is out. There is no question of telling the patient to kind of wait and watch. Either they need active intervention. So watchful. So we have to, as pathologists, we cannot miss out 4 in a biopsy. We cannot afford to miss out Gleason pattern 4 in a needle core biopsy, because that is going to dictate the subsequent management. And if you're saying something as 3 plus 4 versus 4 plus 3, there is a hell lot of a difference. I'll discuss that in the next few slides. Why
most
these
of the
are
people
4?
in YouTube, most of the people in YouTube are saying Arpita, Samriti, all of them are saying 3.
Yeah, why it is not 3? It is why I'm saying, because when you see, it is the typical teaching, and when you see a lot of 4, so you have cribriform 4, glomerular 4, and fused 4, and there are few here and there glands with lumen and some stroma separating it. So this is basically tangentially sectioned, so it's a tangent of 4. It is not a pattern 3 gland. It is a tangent of 4, which gives a deceptive look of 3, and you call it as a 4 plus 4 or a complete 4 area. Similarly, if you go here, these are all 3 glands, but here it looks like fused, here it looks fused, but majority are not. So this is again a tangent of 3. So this is 3 gland. This is 4, because these small glands are tangent of 3, whereas these are, they look fused, but these are probably the part of same gland, which if you cut it again and again, you see the lumen more and more visible. So this is the tangent of 3, not 4. And similarly, this is all 3. And what this one now? The one on the I mean this area. This area is 3 or 4.
So up or down? Which one?
Towards the right. Down वाला तो easy है ना. I'm not going to ask you the down. Down was tripliform. It's classic 4. What about up?
You can use a pointer and point out because probably they're not
ये वाला. Sorry. This area. Within the circle. 3 or 4.
Arpita says 4 from YouTube.
Yes, it's 4. Because on the right, yeah, this is all 4. So you have this is a small cribriform, there's a big cribriform. So this is again another 4 because it's probably one nodule. And here if you see the glands are getting fused. These two are fused. They're trying to make a cribriform. This is also trying to make a cribriform. The small glands. So this is not like it is away from that nodule and they're kind of close to each other. So it is a tangent of 4. How about this one? 3 or 4, the entire slide. Anyone?
Four, sir.
This is 4. This is what kind of 4? This is a very clear cytoplasm. It's probably in a hyperdiploid or a clear cell type of flow. How about this one? They look like rosettes. It is again a 4 with cribriform. It's a rosetoid kind of cribriform. But look at the stroma here. There is absolutely no desmoplastic reaction. It's absolutely clean. No desmoplasia. These are all the nuclei of the smooth muscle cell and the fibroblast. How about this one? This with mucinous differentiation. So whenever you have mucin, you exclude the mucin, you deduct the mucin, subtract the mucin, and look at the glands, how they are kind of. It's basically in prostate cancer, when you do it, you see the glands are separate from each other, they're fused, or they're trying to form some complex structure, or they are kind of they're completely dissoluted into an ocean. So accordingly, it is 3, 4, and 5. So here what you see the glands, the lumens, they're clearly visible, they're separate from each other, there's no fusion. This is 3 with mucin. How about this one? Three or 4?
Four, sir.
Why it is 4? Yeah, you may be correct, but you have to justify your answer. Number one question, are the glands fused?
No.
The glands are not fused. Do you see good lumen in every gland? Or you're imagining a lumen?
No.
The lumen is not clear in all the glands, sir. And it seems like the glands are floating in mucin, sir.
Yeah, exactly. The glands are floating in mucin because some areas. One second. Let me just change my pointer option to this one. Better. Not this highlighter. So this one. So this one, if I say, this one is a gland, right? And this one is a complete gland. And this one also is a complete gland. But there is a clue here. They look like complete gland, but these are not complete gland. They are squeezed, or there's so much of mucin. They're giving a deceptive look of a complete gland. These are actually squeezed gland with mucin inside and outside. So they're actually all outside of the gland. And these are thin strands of cells. And so it's more towards a 5 rather than a 3 or a 4, because these are basically a layer from one gland, is the layer from another gland, or strands of cells with mucin all over the place. And there are some areas the mucin is in the nodular fashion, or it's making a globule, and with glands kind of inside and outside, giving a deceptive look of a gland. So this is like all possibly 5 or maybe 4, but definitely not 3. Is it clear? These are not true glands. These are the pseudo glands which are formed by the mucin. How about this one? So there are strands of cells within a space. There's a cluster of cell within a space. There are some clusters. There is one lumen here, one lumen here. Mostly there is no lumen. So what is it? 3, 4, 5, or
5.
5. So in 5, if you see this 1 or 2 luminal structure fused and you kind of discount it, it's all tangent of 5. This is all Gleason 5. How about this one on the left and on the right? What is on the left and what is on the right? Left is this structure, the dark structure, and right is this below the yellow line.
Left is 4, right is 5.
Why right is 5?
Individual cells.
Left is individual cells. Do you see lumen in right?
No.
What is this? What is this structure? What is this one? And what are these 3? With a limiting membrane. So I'm more confident in saying it lumen versus the other case. Here. The 2 probably juxtaposed here. Best on the basement membrane, I'm saying. So this is a hypernephroid 4 on the right below, and left up is a regular cribriform 4. Cribriform means it's 4, it's not going to be 3. How about this one? This is normal and abnormal. Okay. This structure is normal or abnormal? On the top. This is a normal gland. And what happened is what is there a cancer? If there is a cancer, what kind of cancer it is? It's a signaturing 5. This one? I have shown this slide like a few lectures before. What is this one? This is again 5. Why it is not small cell carcinoma? You see very prominent nucleoli. And the nuclear membrane is perfectly round. There is no wrinkling and there is no molding. No fixing into the convexity of by the concavity of another cell. And prominent eosinophilic nucleoli. This is the Gleason pattern 5. And what about this one? This again cribriform with necrosis. This one is who is going to tell me what is the diagnosis here? The bottom one is just Amakar staining. So forget about the bottom one. What is there on the top one? The cells are like pencil shaped cells. The nuclei are darker and they're like really dark and they're pencil shaped. They look like endometrioid carcinoma. They're cribriform. And there's stacks of nuclei next to each other, making stacks. So what is it? Is it acinar adenocarcinoma or not? This is prostatic ductal. What about this one? You can have a sarcomatoid variant of prostatic acinar adenocarcinoma. This is one such case. This is small cell. we have already seen, and that is the stain. This is prostatic adenocarcinoma with panacell-like granules, which we have already discussed this in our neuroendocrine class. Doesn't have any prognostic implication. So the grade group 1 is basically when you see only discrete individual well-formed glands, which is Gleason 3 plus 3. And the lowest Gleason grade in a biopsy, it is Gleason 6. In grade 2, do not do a 1 or 2 kind of diagnosis, like Gleason 1 plus 4 or something like that. It is the lowest grade is 3 plus 2. And grade group 2 is Gleason score 3 plus 4, which is equal to 7. So what you see predominantly well-formed glands forming 3 with a lesser component of poorly fused or purely formed or cribriform gland. They're poorly formed gland or incompletely formed gland. They're fused gland or cribriform gland. And most likely they're not very juxtaposed to the well-formed gland, little away or in the different pole. 4 plus 3 is predominantly poorly formed or fused or cribriform glands with a lesser component of well-formed gland. When you say Gleason grade 4, which is score 8, 8 can be 3 plus 5, can be 4 plus 4, or 5 plus 3. So it is a poorly formed, fused cribriform glands, a predominantly well-formed gland with a lesser component lacking glands, that is solid areas, or predominantly lacking glands, that is solid area. So either 3 plus 5, so solid is definitely no gland, and 3 is all gland, and 4 is fusing. 9 and 10, which is grade group 5, so anything which adds up to 9 or 10, that becomes lack of glands, necrosis with or without poorly formed, fused, or cribriform gland. Why we are doing it? This is to say the probability of recurrence-free progression. When I say recurrence-free progression, means the patient is doing well, there is no recurrence-free. So if you see the first one, it is on the top. The Kaplan-Meier in this, the recurrence-free, biochemical recurrence-free survival is great. If you go down in 5, it is really bad. Compare 2 versus 3. 2 is 3 plus 4 and 3 is 4 plus 3. So what is the difference? There's a big difference between, there is a huge difference between this one and this one. So there's a decline. So it is important to exactly say how much is 4 and how much is 3. At least you have to be very clear about distinctly say on the biopsy what is the percentage of 3 and what is the percentage of 4, because accordingly the grade group is going to change and that has important prognostic implication. So G1, GG1 to 5, the lowest possible Gleason grade may help to change the perception about the malignant potential, which is usually indolent. G7 is not a homogeneous entity. G7, it is a grade group 2 versus it is very different because they have different treatment strategies, especially radiation therapy. GG4, Gleason grade group 4 with a better prognosis should be separated from GG5 with a better stratification. So we kind of published a paper way back in 2014-15 on artificial intelligence, the beginning, on machine learning approaches to analyze histological images of radical prostatectomy. To develop, implement, and validate a machine learning approach for computer-assisted classification of images from histopathologic preparation of prostate tissue. So you have 210 images, and they're divided into a training set and a test set, then annotated by pathologists. They annotate the benign stroma, benign gland, G3 and G4. And they are classified using RF and SBM classifier. And just to delineate the exact percentage of G4 and G3 using computational. So this is like the blue one is stroma, red is high grade, that means 4 tumor, green is low grade. So then after we divide that, we can specifically say by the machine, which is not always possible. This is good, looks good in publication and not in real life, to say how much is 4 and 3, but you can probably put like 1 or 2 cases like that, not a regular routine practice. You have like 12 or 13 prostate biopsies to sign out in a day. You cannot afford to do this. So what are the GP recommendations? Consistent reporting of Gleason pattern 4 in biopsy and RP specimen with less than 5% GP4 or issue of tangential sectioning, then you have to show that to someone else. Suppose you have a biopsy with very little amount of GP4. So you are confused to call it 3 or 4, or you do not have 3, just 4, and it looks like less than 5% of the entire specimen submitted to you. Please show it to another pathologist. You need to clearly delineate 3 plus 4 versus 4 plus 3. Higher grade again, it is important. I'll come to that. Grading of core versus jar versus case level. If there is a multiple fragmented core in a single jar, give a global Gleason score. If there are separate nodules in radical prostatectomy, you have to say nodule number 1, size, grade, nodule number 2, size, grade, blah, blah. You do not have to say what is the dominant one. Major actors for the future. Cribriform Gleason pattern 4 associated with worse prognosis than poorly formed fused gland. This is important. A cribriform has a worse prognosis than poorly formed fused gland form. They both are 4. Then do not grade if it is a basaloid, squamous, small cell carcinoma. G1 and G3, lesion 1 and 2, requires nodular circumscription, and poor correlation with RP should not be diagnosed in drill core biopsy. I can take a few questions now. Dr. Nadeem, I can take a few questions.
We are waiting for people to ask questions.
Oh, sure, thank you.
Anybody has any queries? You can unmute your
I
mic.
thought I'll break into different this session, because there's a lot of questions that clarify each other's doubt, my doubt and your doubt throughout the lecture. If there's no question,
there are no questions.
Okay, cool. So essential reporting elements for cancer-bearing prostatic needle core biopsies. So the usual scenario is you go for the primary, which is the highest, and the secondary is usually not the next one, it is the worst pattern. Suppose you have 3, 4 and 5 and highest, and 5 is little, but it is the worst pattern. So you say it is 3 plus 5. If you have 3, 4, 5, 4 is the highest, 4 is 60%, 10% is 5, and 30% is 3, that becomes 4 plus 5. So it's the predominant plus bad or worse pattern. Then you write number of cores positive. It is continuous involvement versus discontinuous involvement. That is important. Then you write if there is any treatment related changes. You have seminal vesicle present or not, then you have to mention that and look at the muscle of seminal vesicle in that biopsy, it is infiltrated or not. Just you can write a portion of seminal vesicle present, negative for tumor, or you can have one core with seminal vesicle without tumor, you should mention. Or if there is tumor, you mention that in that core. Then quantification. What is the percentage of involvement? Suppose I have a 1.5 centimeter core and I have 1.2 continuously involved glands, and I write 1.2 centimeter over 1.5 centimeter, whatever is the percentage of involvement of that gland, and I do it by marking it and kind of use the micrometer in the microscope or use a ruler to exactly quantify, no approximation here. Suppose I have a 1.5 centimeter core with both the ends with 2 millimeter and 2 millimeter. So I write in a different way. There are 2 foci of prostatic acinar adenocarcinoma present discontinuously at both the ends or at 2 different areas in a biopsy in a 1.5 centimeter core, 1.2 centimeter distant from each other. Suppose you have a 1.5 centimeter core, there is away from, 0.3 centimeter away from one core, there is a 0.2, and 0.2 centimeter away from another core is a 0.2 centimeter, whatever kind of core, and there's a big gap of normal benign stroma and gland. So I kind of say the span over a 1 centimeter, 1.2 centimeter, they are discontinuous, and the entire length is 1.5 centimeters. So you have to ward it and you make it very clear. So surgeons should not think like it is like 1.2 over 1.5. There are actually two foci of 2 millimeter. They are present discontinuously in a core of 1.5 centimeter, and they are 1.2 or 1.1 centimeter apart from each other. So that thing should be very clear in the report and should be conveyed. If there's a question from the urologist, you should convey it. Then variance. Atrophic is always 3. Pseudohypoplastic is 3. Foamy is 4 mostly, but depending on the architecture can be 3 or 4. Vacuoles, you take out the vacuole, mucin, either 4 or 3, you extract the mucin. Then ductal is always 4. Sarcomatoid is 5. Signet ring is 5. Small cell neuroendocrine, neuroendocrine carcinomas, squamous cell basaloid are not related. If you have one grade present, double that grade. 3 plus 3 6. Abundant high grade tumor with less than 5% lower grade tumor. Ignore the lower grade and assign it as 4 plus 4 8. Smaller focus with mostly G4 or few glands of G3. Since G3 occupies more than 5%, include the lower grade cancer, assign it as Gleason score 4 plus 3 equal to 7. Abundant G3 with any extent of G4. Any extent of G4, you cannot afford to lose that. It is 3 plus 4. 3 grade, 3, 4, 5, classify the highest grade with the grade with bad prognosis. Multiple cores showing different grades. Cores submitted separately with designated location. Assign different Gleason score. Do not try to make up. I make a table and write down these are the biopsies, the primary, secondary, the total. And if there's a tertiary, I mention it. So that way they should know the global picture, the entire picture. Multiple cores showing different grades. Cores were submitted in one container and fragmented, then assign an overall GS score. So these are all we have done. I think that repeats. So what is this?
Can I put up some questions? Hello?
Yeah, sure.
I have
yes,
a
Dr.
lot of
Nadeem.
questions on YouTube. Would you like to take them now?
Yeah, exactly. I can, definitely.
Yeah, because these are related to your last table. So I thought.
Okay, let's go to the last table.
Does Gleason's. Yeah.
Yeah.
Yeah, this one, right. So Pratishtha is asking, does Gleason pattern 5 need to be incorporated in needle biopsy if less than?
Yes. Any little, if it is less than 5%, 3, you can ignore. Other than 3, 4 and 5, whatever the percentage, you have to mention in 2%, you have to mention in the 4 biopsy. That's a great question. Brilliant.
Another question from Nilesh Kapadia. Why METs have better differentiation usually?
That is something called paradoxical phenomena we see usually in a lot of cancers. They look more opened up. I would not say they are better differentiated. Why? If the tumor looks dark, it looks paler they look very, very opened up chromatin, prominent nucleoli and all, they look more vesicular and lighter at the so I have like two hypotheses which I learned during my molecular fellowship. One is the nuclear chromatin is remodeling and changing of the tumor. Nuclear chromatin of the tumor is remodeling and it is undergoing a lot of transcriptional change and hypermethylation changes. So they look more opened up and rarefied. So they look more pale. And the tumor cells are producing a lot of proteins. So the cytoplasm look more eosinophilic and voluminous. So the NC ratio is kind of maintained in, and they're not like high NC ratio kind of thing at a more differentiated thing. And rarely when you see glands are not very quite often visible in a prostatic cancer which metastatic to the lymph node, whereas you do see glands when it's metastatic to the bone. That I kind of tried to look for, I did not find, but few things they kind of say when they kind of go to a new place, they are more active transcriptionally. So the chromatin is more remodeled, so they look more like well differentiated, or like instead of being more clumpy and all this kind of thing, they would look more rarefied with a lot of proteins, so the cytoplasm is more. That may be the.
Nilesh also has another question which he says is, in METs, do you have to score in METs also?
No. We do not have to score in METs.
Yeah,
Just
yeah.
prostate.
We don't score at METs. Yeah, right, right. Please go ahead. These are the only questions in YouTube. That's right.
Great, thank you. Okay, what is this? They are both are from the same case. One is a little low power, one is a little high power. Cancer,
Requesting
low
everybody to participate.
Yeah, please participate.
Yeah, please participate because this is a learning thing. So please come out and speak out, everybody, please. We have
I'm
arranged
actually
this
running a
special
lot.
session only for everybody to participate.
Exactly. Please.
Pratishta says atrophic variant.
Yes, it's atrophic variant. Why Pratishta it is atrophic variant? You have to explain it, please. Please help me out. Why you are thinking it is atrophic variant?
Pratishta,
Why it is
you
not
need to
atrophic
explain.
gland?
Just type out why do you think it is atrophic and why not
Just
atrophic glands.
benign atrophy. Yeah.
Yeah, benign atrophy. She says it's flattened lining. That is an atypical.
Yeah, let me explain. The one thing when I see in low power, in this power, it is blue mucin. The glands are definitely atrophic, but I see a lot of blue mucin. So I'm kind of little suspicious. Is it benign or malignant? Because usually blue mucin is not seen in atrophic glands. Number two, when I go there, I see there is loss of basolateral and apical cytoplasm. Everything what you see in this, yeah. So this what you see, this gland, this cell or these ones, they are very little cytoplasm. So it is atrophic. But atrophic glands, the nucleus is usually look little enlarged, but not this enlarged. And maybe if I blow it up, you see nucleoli, but the nucleoli are visible. So you see the glands with nuclear enlargement with only one layer, absence of basal cell layer, which is always kind of a problem in atrophic gland. So you rarely see the basal cell layer because that is squished with the basement membrane. But you see nucleoli. When you're seeing nucleoli and blue mucin, they are the clue. If you are in doubt, you go for basal stem. So we did that. These are the benign gland, this one and this one. Benign, benign, and these are the malignant glands with loss of basal cell stain. This is again small cell, so we did it. This also we did. This we discussed before, so I'm not going to waste my time. Introductory also we're not doing. We did it before. So let's go to, yes, biopsy to radical prostatectomy grade correlation. This is something we need to know. You have a biopsy report. After a few weeks or a couple of weeks or next week, you get radical prostatectomy if the tissue is. Another thing, in a prostatic needle core biopsy, if we see seminal vesicle wall which is infiltrated by the tumor, or you have extraprostatic fat with tumor invasion, please mention that, because that is something called extraprostatic extension. When there is extraprostatic extension, the tumor is outside the premises of the gland. It is not, the patient is not a candidate for radical prostatectomy. You cannot do radical prostatectomy in that case. So they are dependent on androgen deprivation therapy. So if it is a Gleason score 5 or 6 on biopsy, they are upgraded in about 36.3% of cases in radical prostatectomy. GS 8 on biopsy, almost equal distribution in RP into 7, 8, or 9, 10. 12 to 3% of cases had a biopsy 3 plus 4, 7 or 4 plus 3, 7 respectively with 6 and tertiary 4 at RP. So there are studies showing the grade upgrade. So you have to be very careful when it is 6. It is real 6 or not. So that is one thing. Or it is in others, I mean, for 8, it is a more uniform entity, and rest or we can, it is kind of get away with that. But for 5 and 6, you have to be really sure it is 5 and 6. PT2, using the modified system versus PT3 predominated using the original system. And if it is a GS3 plus 4 versus GS4 plus 3, the probability that the higher number of cases are diagnosed at 3 plus 4 on radical prostatectomy, because we do not care that much on radical prostatectomy when the prostate is out. We really care a lot. It is better, in nutshell, I'll say it is better to upgrade or overgrade on a core biopsy or overcall the thing on a core biopsy than the radical prostatectomy. And if it is a 3 plus 4 on biopsy, has a more favorable disease on radical prostatectomy, and that can be counseled regarding their favorable outcome to the patient while dispatching the report. Again, recurrence-free risk. If it is a 6 or a red group 1, you have a recurrence-free risk of 94.6%, whereas for 9-10 it is 34%. 3 plus 4, 4 plus 3, it is dropping down to 65% from 82%. So, and the relative risk is 4.7. So it is bad. So now we have prediction models like breast cancer to incorporate in the report to say how the patient is going to do well. Organ confined disease is PT2, so we don't have to subclassify. Then group grade changing. So this is another nomogram or organ, this model based on the metastasis and node involvement and staging and the grade group and PSA to call which group the patient falls into. The stage grouping. This is the stage grouping, not the stage. So TNM stage plus PSA plus grade group leads to a stage grouping. So if I tell you something, starting from the bottom, if it is M1, it is going to be a 4B disease. Even if it is M0, but the node involvement is there, any T, it is going to be 4A. Node involvement is not that common. So when you have a node negative and no metastatic disease, if the grade group is 5, it is going to be a high stage disease. So this is kind of difficult to remember, but if you have it printed in your desk next to it, so counseling become easy. So when I counsel, I have a print of this one. I have a print of all these 3-4 things. I keep it inside my drawer and take it out and show it to the patient. So it is more black and white when I counsel them how they're going to fall. And this is, and urologists also, they know more from about the tumor and all. So this thing usually helps them, because when they go to the urologist, they have a lot of questions. So now we have the prognostic models, which are like metastatic castration-resistant prostate cancer or castration-resistant cancer with a second-line chemotherapy. I mean, they are castration-resistant. That means you have given androgen deprivation therapy, or you have taken out both the testicles, and the patient is still not responding to androgen deprivation therapy. So you are in trouble. So from like a traditional one-size-fits-all approach or a blockbuster approach of subjective assessment, broad distinction, and we are in a phase where you need to, where the patient usually fall into radical prostatectomy, radiation, or active surveillance. So we are more into the molecular biological concepts of prostate cancer. Majority are sporadic, they occur randomly. There is a weak, unpredictable clustering of prostate cancer within certain families, which is weak, unpredictable, and because the inheritance pattern is not very strong, it could be multifactorial, genetic, and environmental. Presence 1 decade earlier, if the dad has in 50 years, the son will develop at 40 years. It is an autosomal dominant pattern with high penetrance. Accounts for 43% of early onset, less than 55% prostate cancer. They are epidemiologically distinct, however, they are pathologically very similar to prostate cancer, which are sporadic tumors. Their tumor, they are multifocal, they are in the peripheral zone. The pathologic stage is dependent on extraprostatic extension, seminal vesicle invasion, and lymph node metastasis. If there is positive margin, they're bad. If the high-grade prostatic intraepithelial neoplasia could be present, like in sporadic. So if they are running in the family, but not necessarily going from one generation to other, that is familial cancer. What is hereditary cancer? If it is kind of going from one generation to the other. Familial is just irregular clusters. So there are mutations in the oncogenes or tumor suppression genes that could be insertion, deletion, chromosomal gain, or losses or rearrangement, which are responsible for this disease. These are the various ones, which could be a P10 deletion, which is a tumor suppressor gene, so deletion of P10, gain of c-MYC, androgen receptor gene amplification, MET, VEGF, STAT3, STAT5A, those are all the players for prostate cancer. ETS gene fusion is one of the fundamental thing, which is a temporous ERG fusion, which is responsible for making a normal gland pin and a pin gland into an invasive acinar adenocarcinoma. So still studies are continuing. So if it is a Gleason 6 tumor with none of this abnormality, active surveillance is fine. If the volume is low, very, very low, watch less than 5%, watchful expectancy is fine. But if it is a Gleason 6 tumor, whatever the amount may be, you have one of these abnormality or multiple of these abnormality, they need treatment. They're going to do badly. So this is the linear model. And the pathway, I'm not going to talk about it. We're focusing more on morphology. So molecularly, they can be divided into ERG family tumors, unidentified tumor, FOXA1 tumor, IDH1 mutated tumor, and SPOF deleted tumors. So they're different groups. So and accordingly, we have potential biomarkers for this group to kind of look upon. An important thing is in being loss of DNA mismatch repair proteins, which is again MSH2, 6, PMS2 or MLH1, ATM and BRCA2. Or there is loss of RB1, which is a tumor suppressor gene again, or chromatin remodeling protein deletion. So let's talk a few words about temperous ERG, which is an enzyme encoded by temperous, and it needs ETS transcription factor, which is ERG. ERG is a vascular endothelial IHC molecule through gene fusion, one of the most common genetic alterations in 40 to 70% of prostate cancer. It has diagnostic value also. Its presence is associated with late-stage tumor, early biochemical recurrence, prostate cancer-specific mortality, and if it is associated with P10 deletion, it is again worse. So ERG we can see by break-apart probe. I mean, if you see fusion signal, there is no, if the two signals are fused, there is no problem. If the fusion signals are separate, the red is the ERG signal, the separate means it is broken apart and it has gone and translocated, fused to somewhere else. PCA3, this is something very important, which is what is PCA3? PCA3 and its transcripts. They are collected from the post-digital rectal examination urine sample. And you run an IHC or a FISH test. It has a better predictive value than serum PSA. When it is important and the volume of prostate cancer is very low in the needle core biopsy, or you have a diagnosis of atypical small acinar proliferation, you cannot say it is prostate cancer, or you have a pin gland with pin focus or a high-grade pin focus and a little bit of atypical gland. Just to tell you something, pin is a big gland disease and prostatic acinar adenocarcinoma are traditionally small gland disease. So pin is not classically a differential diagnosis or a mimic of prostatic acinar adenocarcinoma, because prostatic adenocarcinoma, you have pin-like cancer, which is very rare. Majority of the, or almost always, prostate cancer is a small gland. So if temperous ERG is rearranged, the prognosis is bad. And if there is a deletion of P10, the prognosis is bad because the protective factor, the tumor suppressor gene. c-MYC. c-MYC again is a bad player, is a c-MYC amplification. It is not 814 translocation. It is an amplification of c-MYC. We identified that this one, like in HER2, in comparison to CEP8 in HER2, we do CEP17. Here you do CEP8, and it is more or equal to 1.5. The prognosis is bad. Where you see it is a chromosomal, the copy number gain or amplification, and associated with high Gleason score, poor prognostic factor, independent of standard clinical pathologic parameters. Again, the same thing by Kaplan-Meier. STAT3 and STAT5A, they are molecules offering androgen resistance. So we have seen that the castration-resistant tumors, they express a lot of STAT3, which is again the JAK-STAT pathway protein, and pymogide, which is usually given in OCT, Gillis-Dila-Tourette syndrome, can be used in prostate cancer. There are studies coming up which blocks STAT5A. So this is from that study, the top one. This is an androgen dependent cancer, the bottom one, and the top one is an androgen independent cancer. The independent cancer, which is resistant, has a lot of nuclear expression of STAT protein, whereas the bottom one is completely negative. And the neuroendocrine tumors also are enriched in STAT5A. So now, from the blockbuster approach, we are more towards the precision medicine or medicine. There's another test called prostate cancer gene 3 test. This is an additional tool. When the PSA is not high, it is little high, 2.5 to 10%, 10 nanogram per ml, you require a biopsy. And you do a PCA gene test 3. It is because in that way, in the small volume little tumor, you can diagnose whether cancer is there or not, and it is indolent depending on the gene expression profiling is going to do well or bad. Then a few words about hereditary prostate cancer, like breast and ovarian cancer syndrome. Mutations in the BRCA1 and 2. If a male is BRCA2 germline mutated, they have a 7 times more risk to develop prostate cancer to men without a mutation below the age of 65. Once they cross 65, the chances may be nothing or low, but below 65 in young patients, someone with a BRCA2 germline mutation has 7 times more risk of developing prostate cancer. 4 times more in men who carry BRCA1 germline mutation. Aggressive disease with worse prognosis. Higher rate of nodal metastasis and distant mist. Prophylactic prostatectomy is not recommended in NCCN till date with BRCA1 and 2 mutations. So it is not like GYN tract malignancy or breast. In Lynch syndrome, hereditary non-polyposis DNA mismatch gene, particularly MLH1 and MHS2 deficiency, is another thing. Then HOXB13, which is a factor for development of prostate cancer, they're mutated and lead to early onset prostate cancer. This is the case of Lynch with and the predominant one, the MLH1, then 2, MSH6 and PMS2 a minority. They have a twofold increased risk, and risk is more with MSH2 and MLH1. The younger age of presentation, less than 50 years. This is another Lynch case, this intact mismatch repair protein. And the cases which are, this is something I'm going to read it out, which is important for all of us to know from a therapeutic point of view. Lynch syndrome associated tumor, they demonstrate microsatellite instability and absent staining. The IHC wise, there is absent staining of mismatch repair gene, the proteins via IHC. So when you see there is loss of protein. So if you have only loss of MLH1, then that MLH1 loss could be promoter hypermethylation of BRAF gene, or there is an actual loss of MLH1. So you do that. If there is the dimer loss of PMS2 and MLH1 and MSH6, they kind of make a dimer, and MSH2 and PMS2, sorry, MLH1 and PMS2, they make a dimer, and 2 and 6, they make a dimer. So there's dimer loss, then you are really worried. So you want to do a mutational testing to know these tumors have MSI or not. That means mutationally the protein is lost or not. So they are unstable disease, or there is microsatellite instability or not. If a tumor is microsatellite instable or unstable, they have a high rate of immune checkpoint blockade. That means they express a lot of immune checkpoint molecules, which is PDL1 on the tumor cell as well as on the infiltrating lymphocytes. So FDA have approved pembrolizumab as a immune checkpoint inhibitor for microsatellite high, unstable high. When you say MSI high, that means you see the absence by doing a mutational testing either by single gene PCR or by NGS, or you are doing MMR deficiency looking at the IHC. So NCCN says annual clinical assessment beginning at the age of 40 years by doing a PSA at least with a family history of prostate cancer. So typically in any cancer, if the tumor is MSI high, they are more accessible by immune checkpoint inhibitors because they express a lot of PDL1 and PD1. Somatic mutations in prostate cancer, the majority are AR signaling. They can be a phosphatidylinositol 3 kinase, WNT pathway, cell cycle pathway, or DNA repair pathways. Why we do biopsies in metastatic prostate cancer? What is the need of doing a biopsy? Number one, Is it prostate or it is non-prostate? That is to rule out a second malignancy. To rule out a small cell carcinoma, and you do an androgen receptor staining to see the cells are staining with androgen receptor or not. If the morphology has changed to small cell carcinoma. And look at the MSI status in those. If you have IHC, do it and look preliminary, there's loss of any MSI protein or not. There is an increasing evidence and consensus to test for DNA repair proteins or the genes, because these cases can be amenable by PD-L1 blocker or PARP inhibitor, and their sensitivity to platinum-based chemotherapy. This is something HOXB13 and cancer risk. More frequently in women, common in men with early onset of cancer, familial prostate cancer, and then late onset cancers. So there are the genes which are commercially tested: BRCA1, 2, DNA mismatch, the 4 genes, HOXB13, TP53, ATM, which is also seen in chronic lymphocytic leukemias, CHEK2, PALB2, the same as breast, and NBM, it's kind of emerging data. So the NCCN, you need to know BRCA1 and 2 germline testing is done if there is a personal history of prostate cancer, and the grade should be 3+4 or 4+3 at least, and specific family history. BRCA2, anyone who has a prostate cancer below 45 years, and then consider this thing. This is I'm not going to talk about. These are not something we do. So I'll talk about the mimics now. Can I talk about the mimics now? We finish in 15-20 minutes.
Yeah, please go ahead.
In another PowerPoint, I'll put it. Any questions so far? Then we'll start the mimics.
Questions, system, let me check. No, there are no questions. You can start.
So we'll start with this slide. So what are the indications of doing immunohistochemistry in needle core biopsy? First one, I will say, when you see an atypical small acinar proliferation where you are not sure it is cancer or not, or it is atypical large acinar proliferation, you do not know it is cancer or not. Post-therapy setting, radiation. Basal cell or adenoid cystic light changes. It is a benign thing or a malignant thing. Clear cell proliferation. Small cell proliferation. I mean the small cell neuroendocrine kind of proliferation or signatory cells. Predominantly when we use, this is on the needle core biopsy. I'm not talking about when the tumor has gone into some other. As well within when we do IHC in a prostate biopsy, not something outside. When it is outside, you do prostatic marker. Those are PSA, PSMA, PSAP, prostin, and NKX 3.1 and AR. Those are not the stains we classically do in a needle core biopsy unless it is small cell or something like that. So when we do, so we want to confirm there is cancer or not. Or this atypical small, basically we need to confirm the benignity or the malignant behavior or the malignant potential or the malignant nature of the ASAP, which is atypical small acinar proliferation. And something which looks very atrophic. So it's true atrophy or atrophic gland. It is hyperplastic. It's a BPH atrophy, hyperplasia, or it is a tumorous hyperplasia. The time-honored marker is HMWCK or high molecular weight cytokeratin, or we say CK903 beta, 34 beta E12, CK14, CK5/6. These are all basal cell markers. P40 is another basal cell marker. P63 is a nuclear marker. Recommendation is to use both as a cocktail, which one will stay in the nucleus and one will stay in the cytoplasmic membrane. Then pitfalls. A totally benign gland can be negative. Atrophy, atypical adenomatous hyperplasia, and partial atrophy, pseudoatrophic hyperplasia, they show variable negativity and partial staining. If you see one or two nuclei or cytoplasm positive, we talk it as a benign. Can I just have a glass of water and come back in 1 second? Hello, I'm back. Am I audible? Dr. Nadeem, am I audible?
Yeah, clearly audible. Yes,
Okay.
yes, clearly audible.
Yes. Okay, then in entrapped benign glands into tumor, so they may give you a deceptive look. Intraductal tumor growth. The tumor is growing inside the tumor. You do see there's a lining of basal cell. Do not consider it the benign. You should not be using all these markers at a metastatic site. Amacar basal cell markers are only done inside the prostate when you have a question of benign versus malignant. Amacar is not done because I've seen a lot of people doing Amacar to say it is prostatic versus extraprostatic. No, it is not a marker of lineage differentiation or lineage specificity or lineage demarcation. It is just to say the tumor is or non-tumor inside the thing. Then Amacar, it is a cDNA library subtraction of human prostatic cancer, and Dr. Jiang, who first is a typo, who was my mentor during my residency. He is basically the father of Amacar in 2001 from University of Massachusetts, and there are 270 cases, and they say it is a 137 at cancers at benign. It is 100% cancers are positive, but some and benigns are usually 80 to 90% are negative, but some can be positive. When you see strong cytoplasmic granular staining, that is suggestive of cancer. Again, morphology and the clinical scenario, you say it is benign versus cancer. PIN is cancer, so it is positive, but the highest rate in cancer, and the benign stains are usually wishy-washy and weak if at all it is present. But so you use a PIN 4 cocktail, which has one stain for the luminal cell, which is Amacar, two stains for the basal cell, which is one cytoplasmic or membranous and one nuclear staining. Pitfalls. If you see stronger granular cytoplasmic staining, you look in the conjunction with the basal cell marker. Negativity does not rule out a cancer. Positivity alone does not mean a cancer, which is very important. If it is positive, but the basal cell markers are present, so you are either dealing with an intraductal spread of a cancer or it is a completely benign gland. If it is negative, that doesn't mean it is a cancer without evaluating it in conjunction with the basal cell marker. It varies in the variance and irradiated cancer. So this is pink is Amacar and brown is basal cell. So it's the focus of atypical adenomatous hyperplasia. So this benign. This is benign IHC. This is benign, the brown one with the basal cell. This is again benign. These are all, there is no brown staining at all pink. This is cancer. So what are the mimickers of prostate cancer in renal core biopsy? The benign mimickers in a well-differentiated or a moderate tumor is 3+4 or a 3+3 tumor. What are the atrophy? It can be a problem in TURP transurethral resection or in renal core biopsy. Radiation-induced ATPI is again problem in transurethral resection and also in biopsy. Verumentinum mucosal gland hyperplasia. Verumentinum is present as a ridge in the prostatic urethra where both the prostatic ducts open and pour their secretion. So there can be hyperplasia in that area, and our TURP chips, because when you do a TURP, you are basically sampling the central zone. TURP doesn't sample the peripheral zone. The TURP procedure, because you're going transurethral and taking out the tissue surrounding the urethra. So you can have verumentinous mucosal gland hyperplasia. Adenosis or atypical adenomatous hyperplasia, which is different from atypical small acinar proliferation. Atypical small acinar proliferation, when you are not sure it's benign or malignant small glands, which is proliferating. Atypical adenomatous hyperplasia is different. So it can be seen in both. Basal cell hyperplasia in both nephrogenic metaplasia or nephrogenic hyperplasia or nephrogenic adenoma. Presence of seminal vesicle, again in needle core biopsy is a problem. When you look at the granules and the texture of the cytoplasm and the nucleus, they look really bad and ugly. So don't get away by that. You see the muscle and the cytoplasmic color, the brown or the yellow brown cytoplasmic color to diagnose. Then in transurethral section, you do see mesonephric hyperplasia. In needle core biopsy, you have the adjacent rectum, and so that can be picked up. You see colonic mucosa, or in needle core biopsy, if the needle has hit the Cooper's gland, you see those. So let's start with adenosis. It is otherwise called atypical adenomatous hyperplasia. The incidence is 1.6% to up to 20% in TURP and 0.4% in needle core biopsy. It can be multifocal. So what you see here, let's stop here some time. Maybe I'll start with the picture in the top. Like this one is a benign thing with dark nucleus. And you can kind of draw the circle surrounding this nodule. So this is a non-infiltrative small acinar proliferation with some glands which are next to each other. They are really not infiltrative. And here if you go, this is a benign gland. And these are small acini, but the nucleus of these acini, there is no nucleolus, most of them, and there is a little basal cell layer. They resemble the large gland. So this is the same thing in the high power. And this one, you see the basal cell layer. These are the basal cells, the spindle ones. There is a papillary kind of architecture, which is a normal benign gland and surrounded by the small acini. So what are the diagnostic criteria of adenosis versus cancer? Adenosis is usually well circumscribed. It has a lobulocentric or lobular configuration, whereas a cancer is infiltrative with haphazard growth pattern. Desmoplasia is not seen in any of this. Small glands, they share the similar cytoplasmic and nuclear features with admixed large benign glands which are present within the nodule, where the small glands that are distinct from the nuclear cytoplasmic of both the features from the benign gland. Pale clear cytoplasm is seen in adenosis. The cytoplasm has a mixture of blue and pink or amphiphilic in cancer. Blue mucin is very rare in adenosis, is seen in cancer. Nucleoli is usually large, and if at all nucleoli are present, they are not very conspicuous, they are small or medium. Corpora amylosia is common in adenosis, they are not rare or not seen in cancer. Basal cells present and basal cell absent. So this is what. So if I see this one, there is a nodule with these small glands admixed with some of these larger glands. But mostly there are some branched gland. This is the large branched gland. And in the core biopsy, you don't see the entire gland. And this is the benign gland. Yeah. But they're kind of a very clear looking cell. But if you see here, there is some degree of infiltration. The small glands, the little tweaks, they're kind of getting out of the thing. And here it appears to be a little circumscribed. Mostly it is getting out. And it is not a very tightly packed structure like this one, compact, well circumscribed. It's kind of opening up with, and the glands are in between. The nuclear character of this gland and the nuclear character of these glands are different. And this is again in adenosis, you see this clear cytoplasm of a nucleus is more like hypochromatic, and you do not see nucleoli that frequently. And there is a layer of basal cell. Fragmented basal cell is seen in atypical adenomatous hyperplasia, which creates problem. And AMACAR can be diffusely positive in over 10% of cases of atypical adenomatous hyperplasia. So you have to do both the stain to come to diagnosis, but again morphology. This is a cancer which looks like adenosis. You can have problem. Here the nucleus is hyperchromatic, not that, and there is no blue mucin at all in this case. And there's a single nodule, no infiltration, and some benign gland. And that this benign gland and the cancer cell with basal cell here, they look very typical. So here you definitely need stain to answer. So features, they are shared between adenosis and cancer. The glands can be very crowded in both. Crystalloids can be seen in both. Gland can have a small hypochromatic nucleus and nucleolus. Minimal infiltration can be seen in a cancer that may not be overtly infiltrative, and scattered poorly formed glands can be seen in adenosis with compression of the basal cell. So, to differentiate adenosis from cancer. Relations of adenosis to cancer. There is no difference in the risk of subsequent diagnosis of cancer following a biopsy or TURP saying adenosis, presence of adenosis. Adenosis is a mimicker of prostate cancer, which is not associated with an increased risk. So whenever you have a diagnosis of atypical adenomatous hyperplasia or adenosis, in the comment you write, adenosis of the prostate is a or mimicker of prostate cancer, which is not associated with an increased risk of cancer, not to confuse, so that the urologist is not going to be confused. Atrophy. Atrophy can be partial atrophy, simple atrophy, and post-atrophic hyperplasia. When you have a needle core biopsy, do not write benign prostatic hyperplasia and a needle core biopsy. A needle core biopsy is not done to say it is BPH or not. The procedure for BPH is transurethral resection of prostate, which is the central zone thing. You can have prostatic needle core biopsies with hypoplastic change. So you write benign prostatic stroma and gland with hypoplastic change in some. You do see a lot of prostatic atrophy. They're like senile atrophy, like any old person, like in breast, and also in women and prostate in men, they undergo atrophy. So in atrophy, what you see, the first thing is the nucleus looks little big. Why? Because there's loss of basal, lateral, and apical cytoplasm. First thing goes is the apical cytoplasm, then the basolateral cytoplasm. So what they do, they kind of go and compress and hit on the basal cell. So the basal cell layer is usually not visible, and the stroma looks more fibrotic, like it looks a little slate gray and fibrotic here, the stroma. And you can have some inflammatory infiltrate, like in any elderly man's prostate, you see some lymphocytic infiltrate that doesn't make it lymphocytic prostatitis. And you can have this microcystic kind of spaces, microcystic adenoma kind of spaces. This is not hypoplasia because there's no hypoplastic change, no infolding, outpouching, papillation, anything, tufting of the lining. So they're again atrophic with cystic dilatation. And here is the high molecular cytokeratin, just to say it is present. And the atrophy, remember, first the acinar cell undergo atrophy, then the basal cell. So you see more atrophic change in the acinar cell. Basal cells are basically compressed. Then this is sclerotic atrophy. It's cancer, but remember, cancer glands did not show dysplasia much in prostate cancer. And in this case, probably I will go for a stain. Is not very clear. And nuclear atypia and atrophy, whenever you see nuclear atypia, you have to think one thing here. The nuclear atypia is very uniform in cancer. This is a cancer case on the right. What you see, the nuclear atypia is uniform. If you go here, the atrophy, they have some smudgy, big, degenerated nuclei. It's kind of a more of a symplastic or degenerated atypia rather than a true atypia of a cancer. Then partial atrophy. So there is atrophy along with post-atrophic hyperplasia. This is like a normal gland. This is not complete atrophic at all. There is a lot of cytoplasm, apical cytoplasm, lateral cytoplasm, but here this part is atrophic. Then post-atrophic hyperplasia. So this looks like a TDLU, or this is like PDLU, prostatic duct lobular unit. One is prostatic duct is entering and then dividing. So what do you see? Following atrophy, this is atrophy. This little one is atrophy. These are all atrophy, and the blue thing is lobular hypoplasia or adenosis. If you can think about breast, and because prostate and breast are analogous organ, they have the similar kind of PDLU and TDLU, and you see post-atrophic hypoplastic changes. This is again post-atrophic hypoplasia following an atrophy. Then cord-like atrophy looks like lobular carcinoma. They are going in cords. Then atrophic pattern adenocarcinoma. This is important very soon. In atrophic pattern adenocarcinoma, the nuclei is not hypochromatic. They are vesicular, they have nucleoli, may or may not have hormonal treatment, and you see loss of cytoplasmic volume. And there is perineural invasion here. There's enough to here. Benign atrophy would be negative, would be positive, and this would be negative for basal cell marker. To prostatic carcinogenesis, but not proven. Atrophy and inflammation are associated with increased proliferation. Reactive oxygen and nitrogen radicals, they increase the turnover and result in mutation. If the atrophy is associated with cancer, it is not a proximate cause. So it is just an association. Proliferates, you see a florid prostatic atrophy, do not mention in the report to confuse. Basal cell hypoplasia or BCH. It is predominantly seen in about 2 times in the peripheral zone, or 23% of whole prostate needle core biopsy in 10% of cases. What are the features which are present in basal cell hypoplasia but not seen in carcinoma? The basal cell, when they become hypoplastic, they stratify. So there is multi-layering of cells, solid nest, cells with scant cytoplasm, glandular lumen with atrophic luminal cytoplasm, pseudo-cribriform glands. So when you see cribriform structures, but they're not, the limiting walls are not that stout and pink looking, you cannot see those. Well from laminar calcification present within those lumen, intracytoplasmic eosinophilic globules of the basal cell, and positivity for high molecular cytokeratin P63 in the nucleus and negativity for amacar. Amacar is same as racemage. So this is what, there's multi-layering, and you have this pink stuff, they can undergo calcification. And these are called vague or pseudo cribriform. I'll show you, you can have cord-like arrangement here. And the cribriform structures, what you see here is, you don't see this like a typical pattern 4 or cribriform pin or intraductal carcinoma cribriform type. They are like more irregular thing, is rather a hypoplasia of basal cell which are filling up the lumen. Sometimes in hypoplasia, and another thing in hypoplasia, you see a lot of cytoplasmic fraying and fragility and proliferation. The cells and nucleus is dark and hypochromatic, unlike the luminal cell. They have a different look. You can see prominent nucleus. So this is the case where you need stain. When you see multiple prominent nuclei, it is benign or is the multi-layering of basal cell. So atypical basal cell hypoplasia can show true cribriforming with blue mucin-like substance in the center. This is like a true cribriform lumen, blue mucin-like structure. In all cases, you do not need stain. When you have proper limiting membrane, nucleolar prominence, presence of mitosis, you can ask for an infiltrative pattern, absence of calcification, you look for, you do stains to kind of answer the query. If you have 2 or 3 cores having tumor, then you kind of pass it up. You don't have to waste your stain. You know it is a tumor, it could be either way, it is, you are going to be right. So this is atypical infiltrative BCH with nucleoli. So another thing which can be a problem is the presence of paraganglia. When you see paraganglia with nucleolar prominence and present, you see probably this is the nest of Gleason 5. But paraganglia usually have subtentacular cells in the periphery, and the nucleoli are not going to be that prominent like the prostate cancer cells. You do not see, you see some sort of an hypochromasia rather than vesicular nature of a prostate cancer nucleus, and it is usually very well circumscribed, just present in a benign or a very innocent fashion. If you have problem, paraganglias are positive for GATA3 and they're negative for prostatic markers. So you can do it, but nobody really does it. So I think we are done. And then no, I have another one. There's a nephrogenic adenoma. Nephrogenic adenoma is again a benign tumor-like entity which is associated with prior urothelial tract injury, which starts from renal tubule. So if there is injury to the renal tubule during renal transplant or by doing stenting and all, you see the dropping of this renal tubule. So nephrogenic adenoma is a mass along the urothelial tract, starting from the ureter to the penile urethra or in the urethra in the women. What you see, these are nodules made up of nephrogenic cells. Nephrogenic means they are renal tubular epithelial cells, and they are overlapping features with prostate cancer, like presence of tubules, cords, and signet ring-like cells, and prominent nucleoli. They can be very, very infiltrative, and they can have focal PSA and PSAP positivity. And they are negative for high molecular cytokeratin. They can be positive for amacar. So there is the problem. Mostly you can take it out with the history and all. If you cannot, then do the prostatic marker. They're negative for prostatic marker and positive for renal tube marker like PAX2 and PAX8. The different types of infiltrative pattern, colloid-like pattern, cord-like pattern, signature patterns of nephrogenic adenoma. And nephrogenic adenoma is positive for renal tubular marker like S100A1, PAX2. And remember one thing, uh, nephrogenic adenoma can be very, very atypical, but they have a very hobnailed appearance. I've shown in the cases, I don't have that case right now, but if you see the videos in the YouTube, there's one class where I've shown those pictures, beautiful ones. Then pin ATIP. What is pin ATIP? It is a high-grade pin with small focus of atypical gland. So when to call PIN? PIN is a big gland disease. Look at the luminal cell. The luminal cells are either architecturally they are multi-layered, they are forming papillae, or they are forming cribriform structures. There is a basal cell layer present. When you look at the nucleus is enlarged and the nucleolus is visible at 20x magnification. When you see typically Dr. Epstein says when you have nuclear enlargement of the luminal cell with presence of nucleoli at 20x magnification, it is a high-grade pain. Low-grade pain is not diagnosed because there is a lot of inter-observer variability and that lack clinical significance. So what is phenotype? Phenotype is when you see high-grade pain in a biopsy with small focus of atypical gland when you do not know what is it. So what note or comment you are going to write? Adjacent to glands of high-grade pain, there are a few small atypical glands. While these small glands may represent a small focus of infiltrating tumor, we cannot exclude that they represent outpouching or tangential sections of the adjacent pin. So when it's juxtaposed to the pin, you have these little ones. Are they part of this pin or they are different? So we do not know. And if they show a similar staining character with loss of basal cell layer. So there you ask for a repeat biopsy and you say it is pinative, which is high grade pin with small focus of atypical glands, and we do not know, we cannot exclude it is a pin with tangential sectioning or outpouching or the true Gleason 3+3 small volume acinar adenocarcinoma. Radiation changes. This is the external beam radiotherapy. This is the brachytherapy inside the thing with a radioactive seed implantation to the prostate. So what you see atrophy, nuclear atypia. Again, it is symplastic. These are degenerative atypia. Smudging of the nucleus, fraying of the nuclear chromatin, irregular nuclear membrane, no nucleoli. Or you see basal cell hypoplasia, stromal fibrosis, vascular dilatation and damage, fibrin thrombi. Like other organ, you see all these things and you stay away from, be careful of this changes and have the right diagnosis. And you see a lot of desmoplastic reaction, reactionary fibrosis, reactionary fibroblastic and myofibroblastic proliferation. So that case, some mast cells would be there. Don't confuse that because it is all desmoplastic. I'm dealing with a cancer. Remember, prostate cancer do not show desmoplastic. And when you this kind of change, please do a basal cell marker. This is prominent. I do not disagree, but there is multinucleation and you see this smudginess. So what is it? So utility of high molecular cytokeratin detection and diagnosis of radiation-induced atypia in the benign gland. AMACAR is also helpful. They're usually negative. Okay, I think we are done for the evening. I can take questions.
Excellent. You have some stamina.
Yeah,
Right. So let's have it's almost more than 110 minutes of continuous talking. Great. So let us take some questions if there are any. Anybody has any questions for Dr. Mohanty for this excellent lecture, so detailed, touching every part of prostate cancer, right from its morphology to molecular to immunohistochemistry to mimics, every bit of it. I mean, it's like a full class. So that says, thank you so much. Mimics was wonderful.
No question from people?
No, I think
initially there are a lot of questions. Those are really good points.
Yeah.
So any question on the mimics?
Any questions on the mimics? Let's hear. Anybody has any questions on the mimics?
Sir?
Yeah.
differentiation of high-grade pin and carcinoma, any peak,
Okay,
any
so you tell
persistent
me.
peak?
No, that's a great question. Great question. So, do you think high-grade pin and prostatic accidental adenocarcinoma are differentials?
Obviously, sir, differential, but a good
How
peak
they're
I
differential?
actually just
No,
want.
why they're differential? That let's talk about the fundamental thing.
Hello, hello.
How high-grade prostatic intraepithelial neoplasia (HGP) and prostatic accidental adenocarcinoma. What is the basic and the fundamental difference between these two entities? They are not differential. I'm telling you, they are not differential. Why?
Yes, sir.
Because prostatic accidental adenocarcinoma is a small gland disease. The glands are small, infiltrative, going in between the larger glands. Whereas PIN is a large gland disease. When the gland is big, hyperplastic, large, that is affected by PIN. A small gland disease is not PIN. So बात वहीं पर खत्म हो जाती है. It is PIN is not a differential diagnosis of prostatic adenocarcinoma. Very rarely you can have pseudo hyperplastic prostatic adenocarcinoma. PIN is or PIN-like adenocarcinoma. Those are basically ductal adenocarcinomas. They have a history and all these things, but they're extremely rare. PIN is a disease which affects the larger gland or the hyperplastic gland. The luminal cell, basal cell there is preserved, and there's nuclear enlargement, presence of nucleoli at 20x magnification, and the nucleus will either piled up, they look, and even a gland can be partially affected. I can show you in my next class or send some pictures in the group or something. I have a complete pin lecture, but right now it's difficult to open. I don't know in which computer that is. So you have complete circumferential involvement of the gland or kind of partial involvement of the gland, and it is mostly on the luminal cell. Small gland disease is not PIN. When you have a small gland disease, it is cancer or mimics of cancer or something else. But PIN is not in the picture.
Okay, thank you, sir.
You're welcome. Any more
Right.
questions? But that's a great question. That is usually a problem among a lot of people.
Yeah.
It was a problem with me until 2003. It got clarified. I went from India with like 10 years of some 7-8 years of training, but that was my basic problem. मुझे लगता था कि pain से cancer होता है. मतलब pain goes into transform into cancer, but cancer is a small gland disease and pain is a big gland.
Right. Thank you
Okay.
so much, Dr. Mohanty. Excellent lecture. And
Thank you,
really
Dr. Nadeem, for the opportunity.
justice. Very nice. It was an honor to have you here again. And there is a comment from Nilesh Kapadia from YouTube. He says, we want more. Expectations goes higher. Catch him frequently. Great.
Right now. I'm on antihypertensive today. I had a last week. I had a blood pressure of 160 over 100. So it's not controllable by one drug. So they're now putting me on 2 drugs. So I'm going to right now have food and eat my second antihypertensive. But I'm okay. Don't worry, I'm okay. My
Take rest. Yeah.
So I'll definitely take another. With Dr. Nadeem is going to organize, and he's
Sure. We will have a lecture maybe after
after like 10 days or so.
4 or 5 weeks. Maybe just rest for some time.
I need some rest.
Yeah.
Cool. After puja, yeah, that's good. Thank you. Thank you very much.
Thank you, Dr. Mohanty. Thank you so much. So nice of you for conducting such a wonderful educative lecture. Thank you, everybody, for joining. Excellent. Good night. Take care. God bless all of you. God bless you. Bye.
God bless. Thank you.